Hi, this is Janet Braun. Welcome to Competency 8. This material is on hypertensive disorders in pregnancy and preeclampsia. The woman who has hypertension and becomes pregnant is at increased risk during her pregnancy. So pre-pregnancy counseling is ideal for any woman with a pre-existing chronic condition so that the pregnancy can be planned and her medications may be evaluated prior to pregnancy. Some medications for hypertension are contraindicated in pregnancy. ACE inhibitors are known to cause renal failure in the fetus, and statins are also contraindicated, so these drugs would be stopped prior to pregnancy. A woman who has elevated blood pressure in pregnancy is treated with antihypertensives. Labetalol is the most common drug, first-line therapy that we see used for this purpose. ACE inhibitors are contraindicated, and mild chronic hypertension often is left untreated because it has not been shown to improve outcomes. Both the mother and the fetus are at increased risk when the mother has elevated blood pressure during pregnancy. Pregnancy-induced hypertension is also known as preeclampsia. This is a generalized vasospasm that occurs in pregnancy with elevated blood pressure, protein in the urine, and edema that occurs after 20 weeks of pregnancy. It's associated with a number of risk factors that you see listed at the bottom of the slide. PIH signs and symptoms include elevated blood pressure, rapid weight gain, swelling of the face or fingers or any central edema, changes in her vision, headache, and decreased urinary output. PIH causes a vascular spasm throughout the woman's body that affects all of her organs. The blood pressure is elevated due to vasoconstriction, and she has a reduced blood supply to all of her organs, her kidneys, pancreas, liver, brain, and placenta included. So the fetus would be getting a decreased supply of nutrients and oxygen because of that, and all of the woman's organs would be suffering from poor perfusion. There's a low platelet count in PIH, and an elevated hematocrit can mean a significant shift of fluid out of the intravascular space. Here you see definitions of mild preeclampsia or PIH, severe PIH with blood pressures over 160/110 or an increase in her diastolic of 30, and eclampsia, the most severe form, which is seizure or coma caused by cerebral edema in the mother. There's a very high mortality rate for both the mother and the fetus in eclampsia, and so this is an emergency situation that necessitates immediate delivery and leads to an emergency cesarean delivery. Nursing care for preeclampsia includes bed rest in a side-lying position and seizure precautions, so padding the side rails, darken the room, and low stimuli for the woman. We would keep calcium gluconate on hand at all times because it's the antidote for magnesium sulfate, which we'll talk about. Monitoring the maternal well-being is part of the nursing care. Continuous blood pressure monitoring, daily weights, and her labs that are listed here. We would put in a Foley catheter to monitor her urinary output continuously and collect urine for lab studies. Monitoring the baby would mean intermittent or continuous fetal monitoring and non-stress tests or biophysical profile every day to check on the function of the placenta. We continue to support a nutritious diet for the mother so that she can continue to support the baby. We would start an IV and maintain IV access and administer medications to prevent eclampsia. Magnesium sulfate being the drug of choice, she would receive this intravenously. Toxicity of magnesium sulfate would be indicated by decreased deep tendon reflexes. And as I mentioned before, the antidote is calcium gluconate, which we would keep on hand at all times. In eclampsia, the nurse has to maintain a patent airway, providing oxygen for the mother and monitoring her pulse oximetry, turn her onto her side, protect the woman from injury. We don't use tongue blades for seizure precautions anymore. Continuous fetal monitoring, IV magnesium sulfate and Valium to stop the seizures. And then we would have toxicity precautions, calcium gluconate on hand. After 24 weeks of pregnancy, delivery would be considered. Amazingly, the fetal lungs seem to mature more rapidly in the woman with PIH, and so that is a small benefit. IV Pitocin might be used to stimulate a vaginal delivery if the mother is close to having a viable fetus. HELP syndrome is a more severe variation of PIH, and the mnemonic HELP stands for hemolysis of red blood cells, elevated liver enzymes, and low platelets. The mortality rates are very high if the woman goes into this HELP syndrome. As you can see, symptoms will include nausea, epigastric pain that can be severe, and sometimes that pain is radiating to her back or to her shoulders or to the right upper quadrant. The nurse will be observing closely for any signs of bleeding and have blood on hand in case a blood transfusion is needed. This woman would need to be delivered as soon as possible. This slide gives guidelines for IV administration of magnesium sulfate to prevent eclampsia. So women with PIH will be given IV magnesium sulfate. It's a central nervous system depressant, and so it does decrease the deep tendon reflexes. The baseline labs are listed here that we would be monitoring. We would be monitoring the fetus continuously with electronic fetal monitoring. She would be given an IV bolus of fluid and continuous infusion. Her magnesium level would be monitored on a regular basis through laboratory serum studies. Deep tendon reflex assessed every 1 to 4 hours. Urine output every hour, level of consciousness, and calcium gluconate, the antidote, on hand at all times. If toxicity is noticed, deep tendon reflexes are absent or severely depressed, or her respiratory rate is under 14, or the urinary output less than 30 milliliters per hour, we would stop the infusion of magnesium sulfate, alert the NICU because there could be severe respiratory depression in the newborn as well. The woman with hypertension or preeclampsia needs psychosocial and emotional support, as does her family during this time. So this is a very important nursing function, supporting the family's coping, preventing further complications, addressing issues of perinatal loss throughout pregnancy and the postpartum period, and connecting the family with community resources as needed. If the family has other children, this can be a greater stress on the family. Thank you for listening to this portion.